You would think so. Who's afraid of the storm? Nobody. Right. Where's my mouse? Oh, where's Pedro's laptop? He still has the presenter. Yep. Together with you. All right. Thanks, everyone. I'll give a few presentations and start with something more simple. That hopefully after this presentation, at least it won't be confusing weighted imaging, but it would be more like perfusion weighted imaging to you. So besides from what Pedro just told you, we can use novel MRI sequences like arterial spin labeling as a early biomarker for several diseases. And for example, in the case of aging, you can already see in your outpatient clinic whether somebody's prone to more aging-related diseases. But how nice would it be if we can look into the brain and also see wrinkles of cerebral blood flow? It's not only earlier diagnosis or prediction, secondary prevention of people that are carrying mutations that will make them that are very anxious. When am I going to get dementia? So hopefully the idea is that you can scan them more often in the future and see how this is going. And it is a very useful way to monitor novel treatment because it's non-invasive and we can repeat it as often as we want. There's no tracer accumulating in the brain, and the tracer actually decays very fast, which I'll show you in a moment. Does everyone know this graph? Clifford-Jack diagram is a famous graph for dementia, but also other diseases. So the idea is that you eventually, in the end, you can easily see in your patient that he has a disease. But slightly before that, we have, of course, quite large-scale tools. We can look at atrophy at certain parts. And far beyond that, we want to see that parts of the brain have a lower demand for blood flow because they're using less oxygen, using less glucose because they are less active. And so that was originally the idea. Can we use ASL as a way to not use FDG PET to see that there's a difference in metabolism? And that is called neurovascular coupling, the relationship between the neuronal use and the demand for blood flow. So in PET, this can be very clear, glucose PET, and hopefully we could use something like that with ASL. This is another way to turn this around, that the late in life cognitive decline, we know that this is correlated with midlife changes in, for example, blood pressure. And currently, if we want to look at the vascular state of the brain, the best biomarker is small vessel disease, for example, white matter lesions, which are quite clear, but they take long to develop and they won't change. They're not as dynamic, whereas blood flow, we could maybe give treatment or try to have patients exercise, which is actually also what Dr. Villela did, and see if this actually changes the blood flow. So it's a much more dynamic parameter that we can look at. And this is also part of our research. So why ASL? You could also think if patients are really have a mortal disease, then why can we not use contrast? Well, there are also reasons that more and more people are thinking contrast agents might be bad for the environment, might accumulate in the body. It can be expensive for certain parts in the world, and you need a physician on standby. So adding ASL just 5 or 7 minutes to your existing MRI protocol, it's also a lot easier logistically that you don't need to add contrast agents. The gold standard of perfusion is water PET. So with PET, we can also label the water in the blood, and that has already quite short lifetime. So it's about 2 minutes. And you need a cyclotron, a dedicated equipment for generating PET tracers on the site. So dedicated research centers have done this, water PET, and it's not done a lot anymore. We did this to compare ASL because it's a sort of ground truth for perfusion imaging. And then, of course, you can also use CT, which has its own drawbacks. But the nice thing with also with ASL MRI is that we can do more and more novel tricks with it, like Dr. Vilela has showed, and Beatrice will also present on the blood-brain barrier. So we can improve the technique and be able to measure more of the cerebrovascular system. I'll show a few basics and go into some research examples, mainly stratifying it in the neurovascular coupling, so the demand for blood flow, and vascular effect, which is more of the supply of blood flow. So first, how can we simplify it? So in reality, it is a control label subtraction, which I'll show you tomorrow. But if we simplify it a lot, then the only thing we're doing is approximately, in this, or do I need to do this? So approximately we have a labeling plane. So in the neck, what we do is we change the magnetization, and this is called labeling. And the only thing that is labeled, as you know, with MRI is usually protons, so the water in the blood. And the only thing that flows up of that blood water is the arterial blood. And labeling is MRI jargon for changing the magnetization. And spins are MRI jargon for the protons in the blood water. So that's why it's called arterial spin labeling. And then we need to give a certain, if we did this in the neck, we need to give a certain waiting time for the blood that has been labeled to arrive in the brain. And this is called the post-label delay. And this is a very important parameter because you can think that this blood flow and the speed of delivery of the blood from the neck to the brain differs between patients and controls, which we will look at later. But the idea is after this waiting time, we make an image. And what we see is that this image will be proportional to how much milliliters of blood has flown through each 100 grams of brain tissue per minute. So it's essentially blood flow normalized by the amount of tissue. So that means that if your brain shrinks, with a patient with atrophy or not, it should give the same values theoretically. This PLD, this timing is very important. In general, ASL is a physiological parameter, so timing is very important. Things as hematocrit are important, atrophy, motion, as we'll show later. And that also distinguishes it from a structural image where we just use MRI as a way to take pictures. In this case, we use MRI to measure something. And there, the physiology is very important, so you need to take the physiology into account. So if we would, instead of, let's say, this post-labeling delay, if we would make it very short, then you would only see noise because nothing of the labeled blood has already arrived in the brain. If you wait a little bit longer, then it's like an early phase. What you see is an angiogram. And you see this labeled blood entering the feeding vessels of the brain. And so you see the ACA, MCA, and PCA here. And if you wait longer, then we get a tissue phase. And as you see, if you wait too long, then the label starts decaying, which I'll explain in a second. And there is this ideal moment. And as you see, that ideal moment differs between the anterior and the posterior circulation, because the posterior circulation is a bit slower to reach the brain than the anterior circulation. So those things are you all need to take into account. So why is, as Dr. Vilela said, ASL challenging in terms of signal to noise ratio, in terms of the quality? Well, the first thing is that this labeling has a certain efficiency, which is not 100%. So not all the blood water that flows by is labeled. It's usually around 70%. And it depends a lot on how you position this tracer, this labeling plane, and which I will show you tomorrow. So if you see a patient like this that is not hemiplegic, then this is a labeling asymmetry and not a neurological deficit. And so the way you label can give these artifacts, which I'll show tomorrow. Then we have this decay of the labeled blood. It decays with the blood T1. The blood T1 is a bit longer than the tissue T1, and we know T1 from the sequences that we use to look at the brain, T1 weighted imaging. But in this case, the blood also has a T1, and the half-life is about 1.5 seconds. So that means that every 1.5 to 2 seconds, the label that we made with ASL will decrease 50% in its intensity. And so if you would wait 3 or 4 seconds, then you would see nothing anymore. So that is very important. And another thing to account for is that this blood T1 decay, the blood T1, it depends a lot on hematocrit. So that means if you have an old male with type 2 diabetes mellitus, the hematocrit will be high. So that means that the signal will decay much faster. So you underestimate the blood flow. And in a child with anemia, for example, sickle cell disease, the blood T1 will be much higher. So it takes much longer for the signal to decay because they have a low hematocrit. So you will overestimate their perfusion if you don't take that into account. And then there's a third factor that Dr. Vilela already explained, that from all the water in the brain that we are imaging, only a few % is in the blood. So this means that we need to average our labeling trick in a lot of times. So we need to take a lot of images, and we need to dial down the resolution, which is typically 1 by 1 by 1 in a 3D T1 or flare. And for ASL, it's more like 4 by 4 by 4 because of the much lower signal. So these are things that we need to be careful about, and also the venous output, as Dr. Vilela explained. We assume that the label has decayed because after 3 or 4 seconds, it is only a few % is left. But there are cases where the flow is much faster. For example, this is the case of a child with sickle cell disease. The flow is much faster. The decay is much slower because of the lower hematocrit. So you see that there is a lot of venous label left. And we always, also in the way we quantify this sequence, we assume that there's no venous output. Those are things to take into account. And what should it look like if we simplify it? Then our brain is about 1 kilo and requires half a liter of blood flow each minute. And about 2/3 of that goes to the anterior circulation, 1/3 to the posterior circulation, and about 3 times as much goes to the gray matter where the action happens, where the neurons are, and 1/3 of that goes to the white matter. So gray to white matter ratio, as you see here in this contrast, is usually about 3. And that's also a nice way to look at the quality of your ASL image. So these are averaged images across a population, so they look nicer. And if the quality is really good, then you can see that there's a contrast between the white matter and the CSF. Because in the CSF, we assume that the perfusion is 0. And in the white matter, it should be still around 25, and in the gray matter, 3 times as high. That's about the basics. And we go to a clinical application. I can skip this quickly, as Dr. Vilela has already shown. So on single patient level, ASL works very good if you have very high change. So in vascular diseases, you have a major change in blood flow. Also in tumors, you have a major change in blood flow if they want to neovascularize because they're more malignant. So these are all cases where ASL works very well on a single subject. But if the changes are more subtle, for example, in aging or in dementia, then we need much more volunteers or many more patients to scan than a single subject. And the idea is often this neurovascular coupling, where we started with, that we want to see that there are certain regions in the brain that require less blood flow. You can see on single subject level, you can see some cases where you see patterns, as Dr. Villel also showed, that are typically signature regions for a disease. But always you also see a lot of vascular patterns. So I find this very tricky, and we are also doing more group studies. This is an example of a group study. This is a international group with patients with a genetic mutation that will predispose them to get FTD, frontotemporal dementia. And for all the carriers, sorry, all the symptomatic patients, they asked their siblings and their family members to also come. And there's a lot of them that weren't symptomatic yet, so they were controls, but they were carriers of the gene, and some that were not carriers. So if you take a group with about 100 non-carriers and about 100 carriers, for which we know that for certain they are going to get the disease around the age of 50, then you can do this type of analysis. So you can, when you do a t-test, then sometimes you don't find anything because the changes are very subtle. But in this case, when we did an interaction with years to age of onset, which is the age that the parents got the disease. So 0 is usually around 50, and then -10, 40, -20, 30 years of age. Then what you see is that in red, that the carriers of this gene, they go down in perfusion with age, whereas the non-carriers in perfusion, they stay roughly the same. And this happens then in the signature regions where this disease hits you on the frontotemporal region. So on a group level, you can actually do this research, but on the single subject level, there's too much physiological variability and also vascular changes to really see this in every patient. And because there are so much vascular effect, we wanted to also look into this. Can we use this to our advantage? So on the left, we see how it should look like. But in a lot of studies, for example, in an ADNI in the States with an early Siemens ASL, with the same PLD, so the same waiting time, you got images on the right. So a lot of patients, when they're old and when they have maybe proximal delays or distal reasons for their vascular efficiency to be rather low, what you see is that after the same 1.5 or 2 seconds of PLD, of waiting time, those with the healthy vasculature, you get a nice perfusion-weighted image. And those that are more vascularly compromised, you get the angiogram on the right. So this can be a reason to say, well, I'm going to throw away all these angiograms because I want to look at perfusion. But actually, this also gives you information. And so this sort of early phase can show you how the vessels run, if there is collateralization, or what is the vascular efficiency of this patient. And so, as I said, a lot of times they would just throw away the angiograms, but we actually did research to see if that can tell us something. And this is an example of a group of unilateral occlusions that were asymptomatic. And so it means that their perfusion should still be okay, because otherwise they would be symptomatic, right? And if you then look at this example, so you have the same labeling, but what you see is that at one side, after this 2 seconds PLD waiting time, we see this nice tissue perfusion because all of this labeled blood has arrived within the same 2 seconds. And on the other side, where the occlusion is, what we see is this vascular pattern. So you see that at that site, all the labeled blood is still in the vessels. And that's because not because there's no perfusion, because if we would have waited longer than 2 seconds, it would have arrived in the tissue, but that you see that it takes this alternative route. So it takes this collateralization, being the reason that they are asymptomatic, that those collateralizations could develop over time. So the appearance of these vascular patterns can tell us something about the collateralization state, and can also tell us something about the timing and the vascular efficiency. So with ASL, you always have a sort of combination of this vascular pattern, and so how efficient are the vessels to bring the blood from the neck to the brain, and this perfusion, so how much is there a demand for perfusion from the brain tissue. And there are techniques that try to disentangle those, newer techniques also that Dr. Vilela has shown. But in a lot of the clinical techniques that we have right now, you will see a mixture of those. And we have we try to quantify this so you can look at the distribution of the signal rather than the mean perfusion. And we did this, and then we saw that there actually was a lot of correlations about this vascular efficiency. And so the ability of the blood vessels to bring the blood to the brain within the same 2 seconds. That correlated a lot with intracranial stenosis, cognition, blood pressure, white matter lesions. It predicted atrophy after subarachnoid hemorrhage. And it was also able to differentiate different stages of dementia. So I think that there's a lot of what we can use ASL for, both on this vascular side as well as on the tissue perfusion side in research, but also in clinical practice. But that still begs the question that if you see something like this, so this was a study where we asked machine learning to differentiate between AD and FTD, Alzheimer's disease and frontotemporal dementia. And it picked up these two regions that are typical for AD and one for FTD. But then I could also, knowing about this vascular pattern, knowing that the precuneus is also a very distal region for the blood to arrive, I would wonder if this is also a vascular, potentially a vascular reason, because AD patients are usually older, more vascularly compromised. So it is a bit of a curse and a blessing that ASL has this vascular artifact that they are called arterial transit artifacts, but it's also a blessing. So that it can show you a lot also in clinical patients and in research. So that's it for a small introduction. I hope everything was clear. It's a quite difficult technique sometimes to grasp. So are there any questions? Oh, yeah, it's probably if you do turn on two microphones. Are you as moderator also going to ask questions or not?